Let's look at the major adverse effects of commonly used cancer drugs. This video is just a summary, okay? Two drugs from the anti-cancer antibiotics, Doxorubicin and Bleomycin. These include most frequently asked test questions and board questions because they cause irreversible adverse effects. Both have potential life-threatening dose-limiting toxicities. The first one from the class of anthracyclines called rubicins or red devils causes dose-limiting cardiotoxicity. Here, cardiomyocytes are replaced with fibers. Doxorubicin is a prototype drug. This is also a DNA binding vesican, causes extravasation. They can escape from the veins and result tissue necrosis. This can extend beyond the injection site. Second drug, Bleomycin, is a non-anthracycline, causes dose-limiting pulmonary fibrosis and flagellate hyperpigmentation. Actually, Bleomycin hydrolase, an enzyme primarily responsible for the metabolism of bleomycin, is lowest in lungs and skin, especially in pneumocyte 1 cells and keratinocytes. Therefore, accumulation of bleomycin in these organs causes pulmonary fibrosis and dermal toxicity. The next 6 drugs are plant alkaloids. Out of these, first 4 are spindle poisons. Let's look at Vinca alkaloids. Vinblastine causes severe myelosuppression or bone marrow suppression, while Vincristine is a bone marrow saving drug like Christ the Savior. There is no bone marrow toxicities in this drug, but it causes peripheral neuropathy. This can also cause constipation related to peripheral neuropathy. Next 2 drugs are taxanes like Vincristine. Paclitaxel also causes peripheral neuropathy, and Docetaxel, a unique adverse effect, that's permanent alopecia. Next, the topo inhibitors. First one is the topo 1 inhibitor, Irinotecan. I ran to the can. The adverse effect is diarrhea. Irinotecan is a prodrug. Its active metabolite is SN38, which is mainly responsible for this diarrhea. Then Etoposide is a topo 2 inhibitor. Since it makes double-stranded breaks in DNA, mutations can be hidden after resealing, resulting secondary malignancies. Next 2 drugs are anti-cancer antimetabolites. 5-fluorouracil is a fluorinated pyrimidine analog, causes hand and foot syndrome. When the enzyme DPD is low in keratinocytes, drug accumulates in skin, resulting rough, dry, flaky skin with painful redness and blisters, mainly in the palm of the hand and sole of the foot. In addition to hand and foot syndrome, continuous infusion also causes mucositis, while bolus infusion causes severe bone marrow suppression. Methotrexate, the folate antimetabolite, causes renal damage due to crystalluria. Methotrexate is a very small molecule. Its metabolite 7-hydroxymethotrexate is least soluble in water. Therefore, there is a tendency to accumulate in nephrons. Mucositis is another major adverse effect of methotrexate. Patients can chew ice to minimize mucositis. That is methotrexate-induced mucositis. Patients then also keep in mind High dose methotrexate could kill hepatocytes. This is one of the drugs which causes intrinsic liver toxicity, mainly predictable dose dependent direct toxicity. Okay. The next 5 drugs from 11 to 15 are alkylating agents. The 2 nitrogen mustards are typical alkylating agents. Next 2 platinum analogues are atypical. So, Mechlorethamine is the true nitrogen mustard. It is highly unstable drug and is highly emetogenic. They are DNA binding vesicants like doxorubicins, and this causes extravasation. Since it is an alkylating agent, secondary carcinoma is also common due to this drug. The next is cyclophosphamide, and its related drug ifosfamide also, showing the more or less similar adverse effects. Both cause hemorrhagic cystitis, blood in the urine, blood bleeding due to the high corrosive metabolite acrolein. Cisplatin, we call it Cisplatin because more than 90% of the drug is excreted into the urine and can cause renal toxicity. It is an irritant. Please differentiate the cyclophosphamide induced hemorrhagic cystitis, which is a damage in the urinary bladder, not in the kidneys. But platinum analog cisplatin damages nephrons and can also cause damages to the cochlea. So ototoxicity leads to deafness and tinnitus. So what is the big deal about that? Reason? Both, that is the renal toxicity and the ototoxicity, both are irreversible adverse effects of cisplatin. This is also one of the highly emetogenic drugs out of all the cancer drugs. Okay. The next drug is Oxaliplatin. It is a 3rd generation platinum analog without any nephrotoxicity and or ototoxicity, but it has a lot of neurotoxicity. It has a unique adverse effect related to peripheral neuropathy called cold sensitivity, and peripheral neuropathy is also characterized by this drug. Okay. The next one, Busulfan. It is an alkylating agent, causes complete myelosuppression. Like Bleomycin, it is also causes pulmonary fibrosis. Because of its ability to completely suppress the bone marrow, it is a very effective prophylactic agent for bone marrow transplantation that include very short course to avoid pulmonary fibrosis. Okay, that means Busulfan is nowadays not commonly used in chemotherapy due to these 2 major adverse effects, but still useful for. The next drug, it's actually, this section has a lot of targeted therapy, immunotherapy and targeted therapy. So the first 3 drugs are breast cancer drugs. Tamoxifen, it is an estrogen receptor modulator under this class SERM. Its classic adverse effect is thrombosis. Tamoxifen increases the hepatic secretion of clotting factors. Patients who take tamoxifen are at the risk of DVT, that is deep vein thrombosis, and or pulmonary embolism. Then the next drug, Anastrozole, is an estrogen synthesis inhibitor. If you don't have estrogen, you lose osteoclast inhibition. Therefore, patients get osteoporosis. Okay, we can prescribe bisphosphonates to prevent osteoporosis, right? But there is a problem. With bisphosphonates, cancer cells can hidden in the bone, therefore high risk of cancer recurrence. Patients could also be at the risk of osteonecrosis. But keep in mind, without bisphosphonates, anastrozole causes osteoporosis. That is a major one. But with bisphosphonate, it shows different adverse effects. Okay. Then fulvestrant, it is a third and generally well tolerated drug, but often causes hot flashes and headaches. Then Bevacizumab, it is a vascular endothelial growth factor inhibitor, VEGF inhibitor, blocks angiogenesis. Therefore, it can delay wound healing. That is, new blood vessels will not form when a patient takes this drug, that is during the therapy. The next drug is Trastuzumab. It is a HER2 inhibitor, causes cardiomyopathy, largely reversible. Remember, irreversible cardiotoxicity was from another drug, Doxorubicin, that is generally rubicins or red devils. Therefore, we should never mix rubicins with a Trastuzumab because both has heart or cardiomyocyte related adverse effects. The next drug, Pembrolizumab, is an immune checkpoint inhibitor. This has a classic drug-induced lung disease, pneumonitis. Very unique and it can be life-threatening. Then the next one is Rituximab. It is CD20 inhibitor in the lymphocytes. So it can cause infusion reaction. Severe infusion reactions are characteristics of Rituximab. Natalizumab, that is a alpha-4 integrin, that is adhesion molecule inhibitor. Since it blocks neutrophils also, it can cause opportunistic infections. Then Imatinib, that is a tyrosine kinase inhibitor. It can cause edema. It's like severe fluid retention is a characteristic of Imatinib and all the most of the tyrosine kinase inhibitors. Then the next one, Idelalisib, that is a kinase inhibitor and can cause fatal hepatotoxicity. This is actually in a black box warning. Okay. Then if you can study all these drugs, about 25 of them, and you can score well in your board exam and your class exam, and also it is very significant and important for your clinical practice. These are commonly asked questions for USMLE and other board exams, so study well, okay? And let's look at, you may heard about Chemoman, right? It is from the first aid. It's actually created by a physician, but I just redraw this for you. Let's look at that, a quick review, okay? Cisplatin and carboplatin, it can cause adverse effect related to ears and kidneys. So let's look at it. So cochlear and nephrotoxicity by these two drugs. That's why it shows cisplatin and carboplatin. Then Bleomycin and Busulfan. Did you see that in the lung, BB? So these cause pulmonary fibrosis. Then the next drug, Doxorubicin and D and T, Trastuzumab. Both can cause cardiotoxicity and related to heart. Keep in mind why this is important. These are irreversible adverse effects. Those are very significant and you have to study all those. Okay, then Vincristine, and I just put it right here, but you can remember this way. Both Vincristine and Vinblastine can cause peripheral neuropathy, but Vincristine is the most significant one. So you can just remember Vincristine primarily, but I put it right here. Vincristine, Paclitaxel and Oxaliplatin. All these three can cause peripheral neuropathy. Then that is the toxicity is mainly in neurons and it is peripheral neurons. So those drugs cannot pass blood-brain barrier. That's why peripheral, okay? Then cyclophosphamide, C, and ifosfamide, both can cause bladder bleeding, that is hemorrhagic cystitis, so hematuria. And 5-fluorouracil, 5 fingers, that's how I remember, 5-fluorouracil and its uh, prodrug capecitabine, both can cause hand and foot syndrome. Then M, methotrexate, which can cause severe mucositis. Let's look at a case. A 22-year-old female has been treated with the ABVD regimen for Hodgkin's lymphoma, uh, later presented with a pulmonary inflammation and a skin lesion. Which drug is responsible for her symptoms? So let's break it down. ABVD regimen, adriamycin, that is an old name for doxorubicin. The second B, that is bleomycin. V, vincristine, and D, decabazine, that is an alkylating agent. So out of these, the question is which drug in this regimen causes skin lesions and pulmonary inflammation. So doxorubicin, you know that already. Rubicins or red devils, they cause the cardiac toxicity. So that's not the answer. Let's look at this one. Vincristine, that was, remember, that caused peripheral neuropathy. And the answer is bleomycin, because it can, what is the reason? Mainly because of the least amount of bleomycin hydrolase enzyme in the keratinocytes and pneumocyte 1 cells, which can cause pulmonary fibrosis and dermal toxicity. And the second question, a patient is taking adjuvant chemotherapy presented with a severe myelosuppression. His oncologist decided to include a marrow-saving drug in his regimen to save his myelosuppression, the bone marrow cells, okay? So which of the following should be avoided in this patient? Bleomycin, vincristine, filgrastim, and busulfan. The question is which should be avoided. That means the patient is experiencing bone marrow suppression or myelosuppression. So you need to save the bone marrow. So that means you need a drug which will not have or will not show any bone marrow suppression. So bleomycin and vincristine. Remember, these two are saving drugs, right? Marrow saving drugs. Okay, very good. Filgrastim is actually a colony stimulating factor. This can increase neutrophil count in the body. So that is also okay to use in this patient, but you should avoid busulfan. Do you remember the reason? It can cause about complete or 100% myelosuppression or bone marrow suppression. So this drug should not be treated in this patient. Okay. Yeah. Hope this helps. Study well and all the best.